My name is Matt Wixon. I'm an anesthesiologist here at the University of Michigan. I'm also the founding director of RADAR, Raising Anesthesiology Diversity and Anti-Racism, one of the co-sponsors of tonight's event. I'd also like to thank Dr. Mashur and the board at the Association of University Anesthesiologists, AUA, for their support and co-sponsorship of this really important topic we'll be discussing tonight. I'd like to start with a story. This story comes from the Everyday Sexism Project. I would encourage you to check out their website. It's a free international website where people can submit their stories. I'm a first-year student. I'm doing a graduate course, which means that we're all at least 21, with a lot of life experience and a good level of maturity between the lot of us. As part of our training, we shadow doctors during hospital ward rounds. The doctor we were to shadow that day was the youngest and most attractive, which shames me now to think that that was my first thought, out of the group of tutors. I was looking forward to his teaching, which would probably be more easygoing and up to date than all the other tutors could offer. It was obvious from the word go that I stood out. I was the only girl in a group of 4 students, as well as my name being the only one he cared to remember. I was the only one he was addressing, which I thought was quite good. I was being involved. However, as the visit went along, I seemed to be the only one he wanted to demonstrate things on. Without my consent, he proceeded to poke me with his pen on my hip bones and even dared to demonstrate to others where my pubic bone was, as well as other parts of my body. He could have used himself as a dummy, of course. Even though I was flustered, I decided not to appear so. He was teaching us, after all. Everything was in free fall from then. He interrupted his teaching to tell me that I looked like a celebrity, before adding that it might be an ugly celebrity he was thinking of. Last but not least, he joked about me probably being bulimic. Little did he know that I've been having issues with my weight for the past few years. My group thought it was hilarious. To them, I had an admirer. Right. To top it all off, after complaining to head of teaching, a woman, and asking not to be taught by this person ever again, she kindly let me down by saying, "Well, you will have to have him again because that's how we do our teaching. Think of this as a learning point. You just need to learn to ignore comments." That's a real story. It's a real person, and that's why we're here tonight, to talk about the issue of sexual harassment and sexual discrimination, specifically within the field of anesthesiology. I'm so thrilled to welcome our speaker tonight. Diana Lautenberger is the Director for Gender Equity Initiatives. Her portfolio includes research, education, and projects to promote equitable working environments, as well as developing resources for marginalized populations in academic medicine. She takes an intersectional and gender expansive approach to addressing gender equity issues in higher education and STEM fields. Ms. Lautenberger serves as a faculty member for the AAMC's Leadership Development Seminars for early and mid-career women, as well as being part of the AAMC's integrated team dedicated to unconscious bias training and education, trained and certified from the diversity and inclusion consulting firm, Cook Ross, as well as a certified Green Dot bystander intervention trainer. She provides in-depth implicit bias, microaggressions, allyship, and bystander intervention training to faculty, staff, learners, and allied health professionals. She was also the lead author on the seminal AAMC report that was delivered last year around sexual harassment and sexual discrimination in academic medicine. That report was what moved us to invite her to talk about it. So with that, I'll turn it over to Diana. I would invite you to please submit any questions in the Q&A or in the chat. We will have time for a moderated Q&A at the end of the session. If you don't feel comfortable asking your question with your name, I would just suggest that you change your Zoom name to person 1 or person 2 to protect your identity. Thank you again, Diana, for being here.
Thanks so much, Dr. Wixon. And I really want to thank the entire RADAR community for inviting me tonight It is absolutely my pleasure to be here and to engage with you all tonight. And I really want to hold some space for that, that story that Dr. Wixon just shared, and recognize that everyone on the call tonight, we all need to take care of ourselves. And this could have been a triggering story for some folks, but we intentionally wanted to start this way to come into this conversation, understanding how prevalent these experiences are, but hopefully we can get to a place by the end of the hour together where we're really thinking about what we can do and moving the conversation forward, from where we've really talked about this topic for the last several decades. And so to jump right in with that in mind, we have been talking about sexual harassment for arguably, you could say, our entire human history. But in particular, it's really come into the forefront. Folks are pretty familiar with the Me Too movement that happened in 2015 and 16. And academic medicine and healthcare and medicine writ large, STEM fields, really grabbed a hold of this movement and this activism, thinking about and looking in our own house about what really needs to happen. And so I think some of our priorities have shifted over the past couple of years, but we've absolutely continued to think about this. And that was really a huge reason that we decided to do the report when we started collecting these data in 2019, that the report we put out last year come from. We were on the heels of the Me Too movement and really specifically thinking about Time's Up healthcare and how does this really apply to medicine, but specifically academic medicine and these really particular fields that you all are a part of. And so that was a huge impetus. And AAMC, we are a co-sponsor of the Society's Consortium on Sexual Harassment in STEM, and really looking at this issue critically and how we can address it in academic medicine. So I invite you to, again, as Dr. Wixon mentioned, please feel free to chat with each other in the chat. It doesn't bother me at all. I want this to be a conversation, sharing other resources, other experiences, that's absolutely fine. I'll probably go through about 20 minutes of presentation here and then have some prompting questions for you all at the end to get into some discussion. So just to level set and think about how big this problem is, and I don't think that we can overstate this enough. Some folks might be quite exhausted with some of the research, but I think it bears repeating that when we look at the sexual harassment research, we've got huge ranges in terms of the experiences that we are seeing. Generally, when we look at workplace sexual harassment research, we get anywhere from 25 to 80%. Some studies are even, 90, 100%, depending on the industry or the study that you're looking at. But generally, we've got a range of 25 a quarter to more than 3/4 of women experiencing sexual harassment regularly in the workplace in their lifetime. Now, that's all industry, it's all fields. When we think about faculty in academic medicine, for the studies that we used to back up our own study, we've got, again, this huge range of 20 to 70% of women faculty, again, depending on the study, reporting that they're experiencing harassment. And it should be noted that we're also looking at men and we're looking at all genders when we're thinking about harassment, where we also have 13% of men who are experiencing harassment. So this is something that really impacts everyone. When we think about our students and recalling the story that we began tonight with, again, these broad ranges, but overall, when we look at the studies that have been done with medical students in particular, between 20 and 50% of women medical students are reporting experience harassment. And in one of the seminal reports that the National Academies came out in 2018, if folks have not checked out that report, that was really a watershed report, and we'll share some of the information from that. But that report found that medical students, women medical students in particular, are 220 times more likely than non-STEM students to experience sexual harassment. So we need to think about what it is about academic medicine in particular, about these two hierarchical cultures that we have, higher education and medicine, science and healthcare. What is it about these cultures that make our learners, that make our coworkers, our faculty so much more likely to experience these behaviors or these remarks? And really what we're going to be spending a lot of the time talking about today is this idea of gender harassment as distinct from other types of overt sexual harassment. And really the understanding that we've paid so much attention over the years to overt sexual harassment or sexual assault, when really the majority of what we're seeing these days, and really for the past few decades, is gender harassment and can be defined as gender harassment. And really, those rates we think are actually increasing when we think about the experiences that are going on. Now, even though we've shared some of that data with you, we know that almost none of these experiences are formally reported to our institution. So 94%, and again, this is through studies that have been done specifically in academic medicine, when we're thinking about higher education, almost all of these experiences, they might get reported through these informal surveys or through data collections like ours in the study that we did. But through your institution's formal reporting, we're really not seeing these experiences, which means that we're missing huge swaths of information, not just around the targets of that behavior, but also the opportunity to understand who the perpetrators are. And we know very often these are repeat offenders. And so without that ability to identify those folks, we're really missing an opportunity to take critical action. And this has huge impacts on the individual. When we do these talks or when we have these conversations about sexual harassment, it can become very easy for some folks to say, well, is it really that bad? Didn't you look at it as a compliment, or didn't it make you feel good to have someone say that you're attractive or to give you attention? And my personal experience is obviously, that has not been my experience. It has been very damaging. And we know that that also is supported by the research. When we think about the mental and the physical impact that exposure to sexual harassment over time has on the individual. And that comes out in terms of how professionally you show up at work. So when we think about decreased performance, decreased engagement, how willing or likely you are to volunteer for extra service or extra time if you're being harassed at work, increased absenteeism, not wanting to come to work, and really overall, and this bears out in our own study, that those folks who are sexually harassed really have a higher likelihood of leaving their institution or their field altogether. And so I think that this really adds a critical component to this conversation around gender equity when we think about women being paid less or not getting promoted as much. When it has this impact on your overall day-to-day functionality, you can see how that has a professional impact as well. But it also has an impact on the institution. And I sometimes don't like that I have to continually come back to the business case of diversity, but sometimes the numbers and really just the dollars and cents are really compelling. When we know that if sexually harassed faculty are more likely to leave an institution, we know that the startup costs for recruiting new faculty who have left can be in the millions. And there have actually been some interesting studies that are done in terms of the loss of productivity due specifically to harassment has been estimated at $22,000 per employee. And that's not even mentioning or covering the institutional legal fees that might come out, or settling things out of court when some of these arbitration cases might be coming up. And then also this idea of ambient harassment. You may not be the target yourself of harassment, but just that experience of maybe witnessing or hearing these types of things, that's going to have a negative impact on your well-being overall. And so all of these things have profound institutional impacts when we think about how productive our coworkers are, and just the amount of money that we are wasting on not addressing sexual harassment should be enough of a business case for societies, for institutions to take this on very seriously. So again, this was a huge reason why we decided to do this report. We started collecting data as part of our standpoint surveys, which institutions elect to be a part of. They sign up for that service. And so we included these questions, which I'll show you in just a minute. We included questions related to sexual harassment as part of the core survey, so everyone would be taking that. So the sample includes just over 13,000 faculty from 22 different US medical schools. And it's widely representative when we think about public, private, community-based research intensity. It really is a broad swath. And so what we really wanted to focus on in this report, which is a little bit different than other studies that have been done on sexual harassment, is really homing in on this idea of gender harassment. Again, if folks have not seen the National Academy's report from 2018, this graphic is directly from that report. And I think it's so helpful for us to think about the three different kinds of sexual harassment, where the really overt stuff, the stuff that's above the water that we clearly see, we can clearly identify, that's what gets the most of our attention when we're thinking about programs or training related to anti-sexual harassment. But the majority of the experiences of sexual harassment are really all of those things below the waterline. Those things that are really not as easily recognizable to some. They're very recognizable to other folks or to people that are experiencing it all the time. But these are things that, again, are under the water. They're really not really in the public awareness. And so we wanted to focus most of our attention on these behaviors. And so that determined the types of questions that we were going to ask. So we took, some examples from people may have heard of the SEQ, the Sexual Experiences Questionnaire. We took some of those questions and asked folks to indicate, and they could check all if they wanted to, but if they had experienced any of these 5 behaviors, which is generally how sexual harassment is defined when you're talking about doing a survey. But then in addition to that, we wanted to know some more information. We wanted to know if they answered yes to any of those questions. A, would they feel safe reporting that incident? B, do they know who they should go to report it? And C, do they feel confident that their medical school would actually resolve the incident? And so what did we find? We found a lot of really interesting data that was pretty sobering and pretty consistent with the other national literature on this topic. But it also was really helpful in that we knew where we could, we had some baseline data that we can continue to come back to over time. And so in our study, we found 1/3 of all women faculty are experiencing harassment, where we have about 13% of men experiencing harassment. And that also, we need to be very intersectional when we're thinking about experiences of harassment, because for women of color, for folks of color, people in the LGBTQIA community, we can't always neatly categorize the harassment that we're experiencing, right? We can't say this is sexual harassment over here or this is racialized harassment over here. And so we want to make sure that we're capturing those experiences, not only by gender, but also by race and ethnicity. And so across the board in all racial and ethnic categories, we found that women of color experience harassment at pretty similar rates, with Asian women reporting the lowest rates, still at over 1/4. But really interesting, those folks that selected a different or another race and ethnicity beyond the categories that were offered were almost half of those individuals reported that they experienced harassment. Again, along these lines of intersectionality, we wanted to know sexual and gender minorities, what those experiences are as well. And again, similarly to other research we've seen, women who are in the LGBTQ plus community, which I'm not specifically and intentionally not including the T, which is trans, which is a different gender identity. We're really looking at sexual orientation here. But for those women who identify, they are actually experiencing sexual harassment at slightly higher rates than straight women are. Thinking about how this plays out for faculty who have administrative titles, we found that women who have an administrative title, so senior associate dean or a chief or a section lead or a department chair, they actually had much higher rates of sexual harassment, which I think we have some ideas about why that might be if they're in committees or if they're in groups where they're really outnumbered in terms of the number of men that might be around them. But interestingly, also, it held true the trend that men also with administrative titles also experienced greater harassment. One of the biggest outcomes, which is certainly applicable for this group tonight, and I think the reason that we're having this conversation tonight, one of the most important things I think that came out of the study was really looking by specialty where these rates really bear out. And we were really surprised, and again, would love to have some conversation with you all tonight about the rates among anesthesiologists, with both men and women in anesthesiology reporting the highest rates of harassment, with half of all folks in anesthesiology, of women in anesthesiology, saying they experience harassment. And that was similarly reported to women who were in emergency medicine. But still, the rates among men in anesthesiology a little bit higher. So I think that there's clearly something going on in the specialty that we can talk about. And some of the trends hold true, but I think that there are also some really interesting differences where, for example, in physiology, the largest difference between the experiences of men and women we see in that department or in that specialty, where almost no men, only 5% of men are experiencing that, but we still have that national average around a quarter, or around 33, 34%. And so even down the line, when we look at urology, some of the lowest rates, we're still getting a fifth of all women are experiencing harassment. So we know that this is a huge issue in academic medicine. And really, I think looking at it by specialty gives us an opportunity to get more specific about what the particular cultures of these departments are. Another thing that our study did was look at and break out those 5 behaviors that are typically associated with when we define sexual harassment behaviors. Most folks are probably pretty familiar. You don't put on a survey, have you been sexually harassed? You'll usually always get no. But if you put specific behaviors or experiences, your rates are much more likely to go up of, oh yeah, well, I've definitely experienced that. So that's really where these experiences come from. And so again, thinking about anesthesiology and again, emergency medicine, which had very similar rates, we also think that it's really important to look at where are the majority of those experiences happening. And so this I think really holds true across all of the specialties, but the idea of telling sexist stories or jokes, referring to people to people of your gender in offensive ways, or these gender put downs or being condescending toward your gender are really the most frequently reported behaviors out of those 5. Now, again, this idea of understanding for those people who have reported harassment, how safe do they feel reporting, and do they know where to go? What do we do after that? And so we compared the more brighter colors on the right, those are people that did experience harassment, men and women, and the less bright colors, those are people who did not. And so you can see overall the trend of those people, men and women, who experienced harassment felt less safe reporting that harassment, didn't really have as much confidence about who to report that harassment to, or didn't have as much confidence that their medical school, and this was where there was a huge drop off in the numbers, but not as confident that their institution would actually do anything to address the experiences. And so what we also wanted to do in this harassment, because the Standpoint survey, it's not a sexual harassment survey, it is a global engagement and satisfaction survey. It's got all these other questions about your satisfaction with your school and your department. And so we wanted to crosswalk and map those who were experiencing or reporting harassment to their overall engagement. And so again, a huge finding for us was those individuals, again, the brighter colors on the right, those people who reported experiencing harassment overall were less satisfied with their department, less satisfied with their medical school, and less likely to actually stay at their institution. And so this is a huge a signal that we're seeing of just how important it should be for institutions to look at this data in terms of retention issues, overall engagement, productivity, and what we're really getting out of our institutions. Now, that's a little bit about the data. There's a lot more in the report, so I encourage you to go online and check out the report. But the whole second half of the report was also a qualitative study of 9 institutions that we interviewed who are doing promising practices in this area. And we found 10 common approaches across these 9 institutions that they were pretty much all taking or thinking about taking when addressing harassment, and also importantly, trying to prevent harassment. So I'm going to go through just a couple of these in a little bit more detail, but a couple that I won't speak on today that I would really encourage folks to read more up on is this idea of hiring trained investigators. So institutions actually hiring people who have background and experience and training in investigating sexual harassment claims. They talk about their return on investment there to be incredibly important. Also, institutions using proportionate sanctions. So, for a comment that happened the first time, what would the sanction be there compared to someone who has repeat offenses of potentially sexual assault or something that's very, very overt? We're going to have different gradations of what those proportionate sanctions are going to be. And then getting really sophisticated in our reporting. I would point folks to a system out of Vanderbilt called the PARS-CORS system, which is a really sophisticated reporting and tracking software program that actually allows the institution to identify repeat offenders and actually assess their institutional risk. But a couple of the other practices that we found, and again, this is all written up in the report, so we don't need to read this word for word here, but this idea of truly beginning with zero tolerance. I think a lot of institutions have talked about being zero tolerance, but what does that actually mean in practice? Well, really including this in the hiring process of contacting previous employers or potential employees or people who are applying for positions, checking a box saying that they have no outstanding investigations related to harassment or bias at any other institutions. And so what it really means to be zero tolerance in some of your policies. This idea of addressing, again, these less overt, not just because they're less overt doesn't mean they're not still harmful, but addressing these less overt behaviors early and often. The more likely that an institution is going to allow something small, a small comment or behavior to slide, the more likely you're probably having really egregious stuff that people either do or do not know about. So this idea of having cup of coffee conversations to nip behavior in the bud early and often, and again, letting people know what's going to happen if this happens next time. A lot of really interesting work that's being done about how to hold chairs accountable and really making them instrumental, not a roadblock for this process, but really making them accountable to any sexual harassment claims, or having these coaching conversations with perpetrators about their behavior, about their language, and really giving that education and those tools. And this idea of really training beyond compliance. So we all know that we've got sexual harassment training that's mandated federally or at the state level, but how do we really go beyond what is legally mandated to do real scenarios, case study scenarios where people are acting out in that moment? What would you do in this moment? And really giving people that opportunity to ask questions and to really practice. So those are just some of the promising practices that we found in our report. And so I know that was really quick, but wanted to just give you a snapshot of some of the things that were in the report and some things that we're thinking about here at the AAMC. And so I'd love to open it up for questions now. And again, to the extent that you are comfortable, so we can make this conversation really applicable for you all on the line tonight. What aspects of this culture in anesthesiology do we think makes it so particularly susceptible to harassment? And then what's maybe coming up for you when we're thinking about these differences between the overt sexual harassment that maybe we're more historically used to talking about or recognizing, and this idea of these more subtle examples of gender harassment? So these are just a couple of prompts for you all to get our discussion started, thinking about how this comes up in anesthesiology in particular, and then really getting specific about some of those gender harassment examples. But I will turn it back over to Dr. Wixon to get us started in terms of our Q&A. So thanks so much for everyone's attention.
Yeah, thank you so much. Thanks for walking us through the report. Those are sobering numbers. And you're right, that's the reason why we're here tonight. You know, anesthesiology has a major problem. One thing that has come up both in questions that were submitted before and right now in the Q&A is this idea, what you just asked us, why anesthesiology? What about our job, the environment we work in, the culture leads to this? There are two questions in right now that are related. One says, is harassment of female anesthesiologists mostly by surgeons? The next question then it really states, the operating rooms may be the only place in medicine where two physicians work together in real time. Surgeons are more male while anesthesiologists are less so. Does this explain why rates are so high? It's a power differential that plays out daily.
Yeah, that's a great observation. And so I'll just say in our study, we did not have individuals report who the perpetrator was. I think there's a lot more that needs to be done research-wise to understand who these perpetrators are. And I know that institutions, I mentioned the PARS course system, a lot of institutions that are doing work in this area, they are getting very specific about that. There's also a system called Callista that some institutions are using where, again, it will flag if a person's name comes up, you know, you can set the threshold. It will identify this person is a repeat offender and this person is a problem. So we did not actually identify or ask people to identify who their perpetrator was. But you all would know those power differentials in those environments. And I will say, you know, in an OR, in an ED, when we're thinking about these highly stressful situations, we know the more stressed out we are, the more likely it is that our implicit biases are going to come out, and they're actually going to be heightened in those environments. And so that same concept applies to sexual harassment as well. When we are stressed out or in a high stress situation, we're more likely to say things that are back there in that reptilian brain that we may not consciously want to say, but for those things to come out. And I think we'll have to have a whole nother conversation about the environment and the culture of surgery, which we know can be problematic. And we know we've got lots of examples of bullying and harassment that happens there. That's a great point.
Our next question thanks you for being here. I think there's an overwhelming feeling of gratitude for your expertise and your time. And it goes on to say, how does being a bystander affect others in environments where these behaviors happen so frequently?
Yeah, that's a great question. And so this idea again about ambient harassment, which is really something that's just starting to be studied and talked about, is the bystander themselves is also negatively impacted by these experiences. It makes them feel powerless. It makes them feel angry. It makes them feel sad. That's also going to impact that well-being and that ability to perform in that moment. And so I think what we try to do in bystander intervention training is go through different types of modalities of how to actually intervene in that moment, where bystander intervention is actually, it's born out of street harassment, where there is a potentially threatening situation that is physical right in front of you. And so coming up with these strategies about how bystanders can intervene in safe ways that really have a positive outcome. I think we really need to start educating folks more on their upstander skills. You know, we talk about, you don't want to be a bystander, you want to be an upstander, about how to intervene in those situations. Because that could be really difficult when you're in the middle of an operating room or you're about to go into surgery. How can we intervene in that moment? And so teaching people different tools about how to actually intervene, or at least to provide some support for that target in that moment, is really critical.
Thanks for that thoughtful answer. As a follow-up to that, it's noted that the AUA, the Association of University Anesthesiologists, has actually disseminated a follow-up survey to both US and Canadian faculty members to address some of these unanswered questions,
Oh, great.
prompted from the AAMC report of the
Oh,
who and the
fantastic.
what. And so preliminary analyses will be discussed at their annual meeting in April. So
I'd love to hear more about what you all find. That's great.
absolutely. The next question says, what advice would you have for women medical students pursuing careers in anesthesiology who will be entering this landscape of harassment?
Yeah, I think I would really invite other folks if they have, for you all, I mean, you all are on the ground all the time, understanding what these environments are like. And so any other guidance or advice for you all as anesthesiologists in particular would be very welcomed. But I think, we really have a lot of power in our students and our learners who are leading the way for a lot of our diversity, equity, inclusion, and anti-racism work, of saying, it's a new day. We're not going to tolerate this kind of behavior anymore. You can't say things like that. And really pushing the faculty. And I think particularly in these equity and inclusion areas, our learners are much further ahead than our faculty and really pushing the envelope. And so for those learners who are coming into or considering a career in anesthesiology, of course, reaching out to mentors and getting advice and understanding what the climate is like. But I think the more that you can partner with other learners and really drive these initiatives at your institutions, and providing more education, more feedback, opening up these conversations where we realize there is a huge power differential, but learners also have a huge amount of power at our institutions. And I think a lot of the equity and inclusion and diversity efforts we've seen over the past couple of years have really been led and driven by students. And so that's certainly the perspective that we take at the AAMC, is that even though we recognize students are in a huge power differential position, pushing these conversations forward, or saying we want this type of training, or this is the type of behavior that we think is appropriate, can be incredibly helpful.
And to add on to that, you've done so much work around bystander and upstander, training. Could you give us a couple diffusing responses as you train people in the moment? What can we as anesthesiologists say if we see something or experience something?
Yeah, sure. So what we talk about in my bystander intervention workshop, which I'm happy to come back and do some other time, is to come up with phrases that feel very natural and comfortable for you, but that are also very neutral, because there's going to be different stuff that's going to be said at different times. And I think we're always trying to come up with the exact perfect response in that moment that applies to that particular situation. And that's just too difficult to do. And so having one phrase that feels very natural for you so that you can interrupt a particular situation in that moment is most important. For me, I like to say, ouch, I'm really uncomfortable right now. And that can apply to something that's sexual harassment, that's more racialized harassment, a derogatory comment. It's completely neutral in any particular situation. In that case, and that's, nobody can argue with me about that, that I feel uncomfortable, right? And so I'm telling people how I feel in that particular moment. If people want to feel more inquisitive about it, asking, I'm really surprised to hear you say that, or can you tell me more about why you said that, or what makes you say that? Asking these types of questions. I also think that I'm really surprised to hear that from you is a nice phrase, in that extends a little bit of a respectful relationship to this other person of, I know you to be a good person. I know us to have a working relationship. And I kind of can't believe that you just said that. So this idea of, I'm really surprised to hear that come out of your mouth, and I need to process that for a moment while I kind of get my thoughts together. Can some of those different phrases can be helpful in that moment to just diffuse and to at least interrupt in that situation, saying, okay, I'm not just going to let this go. I'm going to actually interrupt this behavior.
Thanks for sharing that. I think that's a great challenge for all of us on here tonight, is think of what is your phrase. And I really love, Diana, how it extends past, sexual harassment or gender discrimination to race-based comments, all of those things, one that will fit in all those situations. I really appreciate that thought. We have another question that states that you mentioned coaching as an option to help offenders improve. Is there evidence that coaching, in terms of corrective or disciplinary coaching, actually causes offenders to improve their behavior long-term?
That's a great question. And the research, I'll just say, is still emerging in this area. I think what we see is that it kind of depends on the behavior. So for those folks who maybe are a little bit more old school and, they're calling folks honey or sweetie, and some of these, maybe less egregious examples, coaching conversations with those folks has been shown to be really effective. I know that this is natural for you. I know you're not intending to be condescending. This is how it's being received by folks. I think in those cases where it is maybe a quote unquote, and I really intentionally put this in quotations because it's maybe not more minor, but we think of them as more minor comments. Coaching conversations around those types of behavior have been shown to be very effective. I think when we're talking about more egregious behavior or behavior that seems to be as a result of clearly a misogynistic perspective of inequalities between different genders, I think coaching conversations are a little bit more different, or their effectiveness is not going to be as pronounced, because there's clearly something that's a little bit more underlying in that person's behavior. And that's where the being really clear about what the proportionate sanctions for behavior really come in handy, of not just the coaching conversation of, okay, you can't say that anymore, but what's going to happen if you say it again, or if you do it again, and I think that second piece is what's often missing, is that shared understanding of, we're willing to let it go this time. If it happens again, this is going to be much more serious.
Thank you. We're shifting a little bit here. It's not just about women anesthesiologists. Men report about double the rate of men in other specialties.
Yeah.
What do we do about that?
I think we got to talk to more people. We need to collect more information, more stories. I think focus groups are a great way for us to understand, and something that I talk a lot about in some of my other talks around gender equity and gender bias is we tend to think about gender equity as a women's issue, but these normative ways that we have assigned behavior to different genders is just as harmful for men, right? Of giving a man a hard time because he's going to leave early to pick up his kids, or, he's going to take parental leave. If people are poking fun at him for that, that's just as harmful. And those are examples of sexual harassment as well. And so I think that's an important kind of fence that we need to get over in thinking about gender equity, is that gender norms hurt everyone. And the more that we can stop assigning these ideas of this is what women do and this is what men do, that's really going to be our opportunity to make more progress. And so I think hearing directly from people about what their experiences are really important.
Thank you. We have two comments that I think are related, so I'm going to read both of them and would appreciate your thoughts on it. The first says, What is sinister about the OR environment is the pressure applied against calling out sexual or gender harassment. Quote, he was only joking, or don't be so sensitive. To the last point, this frequently comes from bystanders witnessing the harassment versus the harasser himself or herself.
Mm-hmm.
And then I think a comment that piggybacks on that is, in anesthesiology, we work in silos. The OR utilizes teams of people, and relationships are very important as teams care for patients. Gender disparities often occur, as you said, in this stressful environment, but it's often hard as a female physician to prove the gender inequity that occurs, or to address it in the moment when the patient's life depends on the physician remaining focused. So I would just appreciate, your thoughts on those. I think those are two really wise comments. How do we deal with it? If we can't deal with it in the moment, how do we deal with it after the fact so that it doesn't continue?
Yeah, so I like to think about, you're only as equipped, or you're only going to be as successful in the moment to the extent that you've had any conversation about this ahead of time. And so, sometimes we're giving people bystander intervention skills, or we're giving them phrases and language, and then sending them back out into these environments. And those teams, those sections, those units, those departments, whatever your local environment is, has had zero conversations about these experiences, intent versus impact, what's okay. And so I really look at this as a both and of institutions, and even bringing it down to the most local level that you can of your most local team or unit that you're working on, whatever that might be for you. We have to have conversations before the fact if we are going to actually be able to intervene and be successful in that moment. And, some of the comments and the observations are absolutely right, that it's often the bystanders or other people in the room who are kind of giving the pass, right? And we talk about this in ways that dominant culture perpetuates itself of, that's people keeping the status quo because they don't want to be seen also as someone who is going outside the norm, or going outside the status quo, or making waves. And so, in those actual exact moments of, it wasn't funny to me, or regardless of what their intent was, it was really harmful or it was really hurtful. Those types of intervening in that moment can only be as successful as the fact that we've talked about it before that. And so just this idea, again, of continuing education, and it doesn't always need to be a training. It can be a debrief afterward of, maybe we can't say anything in that moment, but pulling that person aside and saying, I know that you were joking, and I just want to let you know, I think I've got a pretty good sense of humor, but it really hurt my feelings and it really made me uncomfortable. And we don't need to make any bigger a deal of that. I'm just letting you know how it affected me. And so sometimes I think, it doesn't need to be this huge, I reported this person, and it went through this whole investigation process. But having regular, frequent conversations, not just about sexual harassment, but all of these equity and inclusion issues, they're all interwoven and they're all connected together about how we don't want to rock the boat. And that's our dominant culture telling us, this is how you get in line. This is how we continue to keep the same people in, positions of power. And so we have to have those conversations as well. I know it's not a perfect answer, but from our vantage point, it's just as important to do the conversation before as the intervening during.
Thanks for that. Related to that, you had talked about standards and policy. And there was a comment that while I was rotating in anesthesia, I noticed a lot of inappropriate comments were made. However, no one seemed uncomfortable by the comments, female and male staff included. I wonder if harassment is more common in facilities who have lax standards versus hospital systems that have a no tolerance policy. Could you comment on that in the study, what you saw?
Oh yeah, we see huge differences between the institution policy, the College of Medicine or School of Medicine, and then what's going on at the hospital or the health system. And those are really things that we need to rectify. And sometimes it's vice versa, right? The institution's doing really great stuff, but the hospital hasn't done anything. And so as we're getting, I think, continually more and more reliant on health systems and kind of getting sucked into health systems and things like that, it's going to be really important for us to make sure that our policies are in line, or that we're at least talking about those particular things. And that does become an issue where maybe the institution's policy is X, Y, and Z, but all the harassment is happening at the hospital. and there may be no policies in that area. And so getting those two entities to talk to one another, I think becomes really, really important. And a place to often just start is just taking an audit of what your policies actually are. One of the schools that we interviewed, the Mayo Clinic, they said that was the first place that they started, was just, what do we got? We need to know what policies we actually have, and then work from building all of their policies in a collaborative approach after that.
A question that comes to mind for me is, after something egregious happens, and has been mentioned, we work in small teams often, day in, day out. How do you heal from it? How do you move on? What does that process look like?
Oh, that's such a great question. I think that there are lots of different examples of restorative practices that, beyond just going to your therapist, but a lot of other restorative practices. And if people are interested, the AAMC, this is not a commercial or a plug, but it really is related to this idea of restorative justice. We are starting to offer some workshops and train the trainers on restorative justice, where it's an actual healing process, just like you're describing, between the offender and the target. And establishing that conversation, that relationship. How do you facilitate that healing? There is a whole written about research practice called restorative justice related to this, of healing after moments of harm. Sometimes I think when we're talking about sexual harassment, depending on what the behavior is, I don't always think restorative justice is the right approach. If we're talking about sexual assault, or things that maybe are more egregious. That's my personal opinion. Folks that have gone through that process might have a different opinion of it being really helpful for them. But I cannot underscore enough how much the healing process is really, really important, because especially, all of my years of doing gender equity work, there is this baggage that we carry around, of this chip on our shoulder. And for many folks who are marginalized, you carry that with you all the time. It makes you put your defenses up. It makes you less likely to be engaged with other folks, or just a little jaded. And so I think that healing process can be really, really important. And so whether that is a process that happens with your students or learners, with coworkers, if we are hosting, intergroup dialogue discussions about that, it is something that I think needs to be heavily and expertly facilitated. But I do think that there are some really good models out there to do that.
Thank you. A question. Do you have suggestions for steps that medical students, residents, or individuals in non-leadership positions can take to advocate for change within their institution?
I think that there are lots of really great medical student groups that are active, that are getting really involved in activism, whether it's, White Coats for Black Lives, or Medical Students for Choice, or, all of these other groups. I think there are fantastic examples of learner-led grassroots activism. I would say that the more you can get as much momentum as you can and get as many people signed on as you can, that's really going to give you strength in numbers. And also using the AAMC to do that. So we have 2 learner groups, the Organization of Student Representatives, the OSR, and we have the Organization of Resident Representatives, the ORR. And those are two national networks that are made up completely of students and residents. And it's a national leadership position, and you get to get together, you come to the AAMC meeting, you can bring these types of issues to a national stage. And so I know the ACGME has started a couple of these types of groups with their residents, but looking to national networks, and we function, I think a lot of people get used to the AMA model, which is very different than how the AAMC or ACGME work. But getting involved in those national organizations, I think, gives students a huge platform to, even if it's just, a webinar wanting to highlight some of this information, you can do that with other medical students across the country. So you don't always have to go it alone. Some students end up doing that, and they've got their own splashy website, and it's great. But you can also use some of these national organizations to help.
Yeah, we've got two related. I know we're getting towards the top of the hour. There's so many amazing questions.
Time is flying.
It's been a really
we could be here all night.
We could be. Two related questions. One is from a female anesthesiologist saying, I wonder if some of the reports from anesthesiologists relate to the lack of understanding of what occurs in our field. People are unsure if we're actually doctors. I'm often called a nurse or told the patient is waiting for the doctor. We also have a unique relationship with nurse anesthetists that can confuse the issue even further. And I think related to that is a comment that as an educator, my learners have complained of gender bias where faculty, patients, or staff think the female learners are either not physicians or are not senior, or worse, are ignored.
Yeah.
What do you think about that? And do you have suggestions for how to help address this?
Yeah, we hear about that all the time. And I think that's one of the most frequent microaggressions that happens, not just to women, but to racial and ethnic marginalized folks as well, of just assuming you're not the physician, even if you're wearing a white coat and you walk in, repeating, I'm Dr. So-and-so, and all of our unconscious biases are just at play, and people will kind of see what they think that they want to see. So in addition to reintroducing yourself as the physician in the room or the doctor, I think this is where allies can be incredibly helpful. And so working with attendings, even working with other men who may be residents, who may be other students. I mean, I think we hear a lot of examples of women attendings walking in with their male medical students, and the patients addressing the male medical students. Even for those learners in that moment, or anyone who's coming into that environment with someone who has a more privileged identity, we have an opportunity to step in those moments as well. And so not leaving it always up to the marginalized person in the room, but how can we give better allyship skills to our men, to our attendings, to other people who are going to be maybe in a position of power. And I realize it's not always the case. Sometimes you're the only one and you're walking in by yourself. And is there an ally that we can grab and bring into the room as a support to say, this is actually your physician, or I would like for Dr. So-and-so to really walk through this case with you, or to really walk through the next steps of what's going on. And if they are ignored, which again, we hear about all the time, that is, again, that opportunity for that person to say, appreciate that you have questions. This is the physician. I direct all of your questions to, this person. So again, these conversations around allyship, what does it look like? What does it definitely not look like? And developing some of those skills beforehand, because we can't just do it in the moment or expect people to just step in and do it in the moment. We have to do some training and education and have these conversations ahead of time before we actually get into the room.
Yeah, I think that is such a key point, that we need to be prepared for the situations. We everything else about our job we trained for, right?
Yeah, exactly.
Scenarios that rarely happen. I think we need the same approach.
Right. We practice everything else. So
we've got to practice this. The last question for tonight is a little bit of a pivot. It's a comment that most of the harassment that this person has personally experienced has been from patients. And then their question is, what can institutions do to address harassment by patients. And I think that's related to this last question. Often I'll have patients think I have a female trainee who's not a physician. So what do we do about that?
Yeah. So patients is a whole other bag. And so we did not address patients in our study because we really wanted to focus on this kind of more peer-to-peer, what we think of as workplace harassment. But we know that very often this is where you're getting the majority of biased behavior, harassing behavior, bullying behavior. And so that's where we really need to rely again on those hospital policies. What are the policies related to patient harassment? And there is actually a forum that the diversity officer at Penn State, Lynette Chappell-Williams, she's put together every other year or so a forum on those institutions that are bolstering their patient harassment policies so that you can actually fire patients. And so I do think that that's a little bit more delicate of a conversation when we talk about intervention skills or allyship skills. I think all the stuff we just mentioned about allyship still apply. And we have the added level of we don't always know what state our patients are in. And if they're in a state where that kind of conversation is not productive, or who knows if they're out of their mind on something, on a substance, or who even knows. You're probably going to take a little bit of a different approach with that patient. And so all of that type of intervention training, I think, has to be specifically tailored to patients. And this is another area where hospitals and health systems really should be looking at their patient policies about what they are going to support or tolerate in terms of how to really support staff, students, learners, everyone that's actually going to be interacting with those folks. So that's a really great question. And we kind of think about them in two different worlds.
Yeah, absolutely. Well, Diana, thank you so much. From Radar, from the AUA, from everyone who was on here tonight, and we'll watch it after. Thank you. You are an expert. You are leading change, and we're just so appreciative. I hope that we can have you back. There's so many more things that we can talk about. So you will be back. I certainly hope. This has been remarkable. Thank you.
I would love to. Yeah, we could have gone all night. I've got my contact information up here. Please, I welcome and encourage folks to reach out to me. Really want to thank everyone. There was such fantastic participation tonight, and I really hope that I get to see you all very soon.
Wonderful. Thank you all for being here. Stay safe.
Have a great night. Thank you. Bye-bye.